Hello there. So sorry, the connection, Wi-Fi connection wasn't great, but now it's much better. So today is the finale session with Dr. James Gohar at Viva Eve, and today we're going to discuss in particular the relationship between fertility and fibroid treatments. And especially, I'm very curious about UFE or uterine fibroid embolization. So we're just waiting on Dr. Gohar to join, and then we can start the session. And here we go. Go live. Dr. Gohar!
Hi, everybody.
Sorry, I'm a little late, of course, and I always try to do my best to be on time. I'm never on time.
Fashionably late, Dr. Mary. Fashionably late.
So, uh, so we're very, very excited. First of all, I am here in your office, and I came to see the office and do it from the other room. It's really, really beautiful office. It's amazing. I ran from West Side here to kind of see it. I wanted to be close to.
Welcome, Dr. Mary. We're so happy to have you here.
Thank you, thank you. So yeah, I was saying that this is our finale session of the fibroid treatment. In particular, I'm interested in UFE or uterine fibroid embolization and fertility. So we're gonna focus today mostly on fertility, if that's okay with you. Now, like any session, I'd like the first 2 minutes to for you to introduce yourself, please, to our audience, and what is Viva Eve, and your specialties.
Of course, yes. So again, my name is Dr. James Gohar. I'm a practicing OB/GYN and the co-founder and CEO of Viva Eve. We are a group of 18 providers, 100 individuals, over 3 locations, Forest Hills, Astoria, and now Manhattan. Within our team, we have 13 physicians and 5 mid-level providers, including nutrition, which is a new service that we recently launched that we feel really complements the rest of our group very, very well. And of course, as Dr. Mary was alluding to, we're a team of multiple specialties, OB, gynecology, diagnostic radiology, interventional radiology, anesthesia, and we have a couple of other ones that we have up our sleeve, but we're going to wait until they're ready before we announce them to the world. But ultimately, the way we think of it is we like to have a comprehensive women's health approach to women's health, which I know sounds very radical and unusual, but it's something that I think is it's unique and something that we think really works well for us and for our patients.
Well, that's great. So women. So your goal in Viva Eve is to have women, any issue with women, to be handled in Viva Eve, which I really like the idea. So we need to talk. Maybe I'll join you because I really like your office.
Thank you, Dr. Mary. We'd love to have you. No question.
So that's great. So yes, so for everyone, I met Dr. Gohar a few years ago. He started at Forest Hills, like he said, and now he's in Manhattan, prime location. It's really amazing. I trust Dr. Gohar 100% with my patients, and we've had this relationship where really my patients, I think the only doctor they say they like more than me is Dr. Gohar. But I'm, of course,
I think they're just being nice to me, Dr. Mary, but
I'm more handsome than you, so this makes up for, you know what I mean? So, last time we talked, just a reminder, we talked about treatments of fibroids. We talked about surgical treatment, which is myomectomy, meaning removing the fibroids surgically, whether through the vagina or through the abdomen or through laparoscope. And then we talked about UFE or less invasive procedures. I like less invasive procedures. My patients like less invasive procedures. So we talked about medications. I don't like them because they put patients in menopause and they give them a lot of side effects. And then we talked about UFE, which is uterine fibroid embolization, which basically is, my understanding, there's a lot of versions of UFE. It's like iPhone. The first iPhone is not like the iPhone 10 or 12 or whatever number we are now. So tell us a little bit about UFE. How did it change over time? And why patients, especially fertility patients, they should seek this as an option for them?
Yeah, I think it's a great question, Dr. Mary. Look, I mean, I think the way you framed it is right on point. It has evolved so discovered, and ultimately invented. It goes back to France in the late 70s, as the story has it. There was a neuroradiologist, a radiologist who focused on a different part of the body and who came up with this idea of stopping the blood flow that went to certain parts of the pelvis, especially when it related to certain types of surgeries. So when they started, they actually started with two groups. They started first with this experiment with patients who had cancer. So mainly, patients who had to do major gynecologic surgery due to cancer, mainly hysterectomies. And they also started with a second group with GYN oncologists, and then the second group was with gynecologic surgeons when they had to treat fibroids. And so when they started the concept, the theory was they were going to stop the blood flow that went to the fibroids and or to the cancer, right? And then make the surgery safer. Because the biggest problem you have with these types of surgeries, where you would be in the pelvis for hours at a time, was bleeding. That was the biggest risk factor. So the cancer doctors, when they came in, they would embolize. The technique in the past that Dr. Mary is referring to is they literally would go in and shoot indiscriminately embolics everywhere within that area. Why? Because they would want to get any vessels. The vessels in the pelvis are notorious for being extremely rich with a lot of what we call anastomoses, which are connections between the different vessels. And so they would literally go in on purpose and try to get everything they could. And so the cancer doctors would find, when they were doing the surgery, that the bleeding was much less. It was a much safer procedure. And so they would go back, these GYN oncologists, to the radiologist, be like, yeah, thank you so much. What you did was terrific. Please do that again for my next patient. And then they went to the OB/GYN doctors, and they would do the same thing. But interestingly enough, something else happened, is when they would go to these OB/GYN doctors to go do this for the fibroid patients who need to do myomectomies or hysterectomies, the doctors would come out and say, no, our patients, after we finish the procedure, yes, they have very little bleeding, but our patients don't want to do anything else after. And so then they went like a step further, and they interviewed the patients. And the patient said, well, guys, hold on a second. Whatever you guys did, it worked. There was no need for us to do surgery because, you guys had actually solved my problem by doing the embolization, so I'm not going to proceed and do the myomectomy hysterectomy because I don't think I need it anymore.
That's cool.
So this is the aha moment that started. And from there, the procedure really evolved. And to get to your point, Dr. Mary, the way that the procedure was done historically has really evolved quite a bit. Initially, they used very rude embolics that were, quite crude and were not, as advanced as what we have today, number one. Number two, they were not very specific in their location. And over time, we've become a lot more pinpoint, a lot more precise. We use external imaging to allow us to be able to visualize in real time exactly what we're closing and when and how. And even further, what they do now is, it's something we specialize in, is what's called a radial approach, as opposed to just a femoral approach, where we actually our interventional radiologists are able to go in through the radial artery as opposed to the femoral artery for about 95% of our patients. And what this translates to is a far shorter recovery time and an even lower risk profile. Even though the risk profile is extremely low to begin with, it's even lower with this because the radial artery is it's a better access. People often will ask, well, how do you go from the arm all the way down to the pelvis? But I can get into that later.
So radial artery meaning, just to explain to our viewer, is that it goes all the way from here, you go all the way down, and then they shoot some like little balls or something to clog the vessels. Is that right?
Correct. Correct. So essentially, these embolic materials. Let me first address your point, Dr. Mary. Yes, they go in from the arm and they go straight down. Some people, often who are not in the field, this is my first conversation I remember having with our head of interventional radiology, Dr. Bilal, and the rest of the group. And I remember us having this conversation, and they were explaining to me why that procedure makes a lot more sense often than the femoral. And the reason is because the anatomy of the blood vessels literally point downwards. And so when they go from the arm, it's actually a straight shot, and you go with the anatomy, as opposed to when you go from the leg, you have to make sharp angles and sharp turns. Both are doable, but they actually can do the radial faster and more efficiently. And more importantly, the recovery time is a lot faster because literally after an hour or two, a patient is standing up and able to walk home, as opposed to having to lay flat for a couple of hours after the femoral. The femoral is still a very tried and true approach. There's nothing wrong with it. and some patients have to because of their anatomy. But it's just an advantage that a few places are able to provide.
Right. So now, the way you do them, my residency, 20 something years ago, believe it or not, we used to say if you're doing embolization, patients might go into menopause because you're basically choking the fibroid. Maybe those material are going to the ovary and put patients in menopause. So I've seen it also in the past. But tell us why it's different and what is the chances of someone doing now UFE and going into menopause as a side effect of the procedure? Because that's commonly asked questions.
Yeah, it's an excellent question, Dr. Mary. And when I was training, it was the same type of thing that we were learning. And I think what's happened is, like you said, the procedure itself has evolved quite a bit. The data has also evolved. We used to believe that if someone was thinking about getting pregnant anytime in the future, they shouldn't even consider uterine fibrillation. And we learned that that's not true at all. In fact, we have tons of patients who get pregnant after. It's really a matter of just risk, right? So we have risk for every procedure. When we do a myomectomy, the risk, of course, could be bleeding. It could be, damage to the cavity, damage to the tubes, even, God forbid, hysterectomy if we run into trouble. Myomectomies are notorious for having a lot of blood supply and leading to, other procedures that need to happen in order to make the procedure safer. The fact of the matter is the risk profile, based on the latest data, we've studied this so much over the years, is between 1% to 3%, depending on the literature. Now, at the end of the day, 1% to 3% is a really low number because you're really saying between 97% and 99% of patients will not have an issue. That said, this is a very personal topic and it's very personal for the individual. If it happens to you, it's real, right? And so the way that we approach this is we talk to our patients. We say, look, there's multiple factors, and Dr. Mary, you can speak this better than I can, that impact fertility. One, if someone already has fibroids, it's going to affect and impact their chances for fertility, depending on the location. Two, often patients who have symptoms with fibroids tend to be older by nature, right? And so you've had more time for the fibroids to develop, more time to develop symptoms. So if you're in your mid to late 30s, early 40s, that we already know. We know that egg quality is a significant factor in fertility. The third factor, of course, is, well, what if someone already has trouble with fertility prior to a procedure, whatever that procedure is? So it becomes very hard from a research standpoint to really pinpoint and remove these confounding factors. And so we say to our patients, we say, look, this is our best understanding of the information. We have no perfect answer for how to treat this problem without any downside, whether it be an embolization, whether it be a myomectomy, whether it be medication. All of these carry specific risks associated with them. Even doing nothing carries risks. And so what we say is, look, if you're going to proceed with an embolization, it really depends on your profile. It depends on your personality type. Some people, they say, look, 1%, 2%, 3% risk, I'll take it. I just want to feel better. And that's what I want to do. And if, God forbid, I don't get pregnant for whatever reason, whether it be related to this or not, I'm perfectly okay with that. We have other people say, look, even if the chances stressing about this every night. And so we say to our patients in those situations, either we get pregnant first and we treat the fibroids, or we work with someone like yourself, Dr. Mary, and we help you freeze your eggs. We will work with you on putting together a plan that will help you ultimately address this issue in a proactive manner and reduce that chance, no matter how small.
So look, my thing is, and I tell patients, if you're gonna do myomectomy, especially if it's abdominally, you have to wait 6 months before you get pregnant because you want the uterus to heal the scar. Otherwise, there'll be problem and the uterus can rupture. So to me, and time is of essence, right? So to me, I always tell patients, freeze eggs first, then do a fibroid removal or UFE. Now, with the UFE, how do you, before you send patients to me, you cancel patients about egg freezing? And after the UFE, a common question patients ask is, what if the uterus, does it affect the lining? Does it affect blood flow to the uterus and lowers implantation? Because that's another concern.
Yeah, it's a great question, Dr. Murray. And I think going back to how we counsel patients, I think you and I counsel patients in a very similar way. I think it depends on what we often will ask our patients is, what is the number one priority? And then one patient will say, look, I want both. I want to deal with my fibroids, and I want to get pregnant. We're like, okay, that's fine. But what's number one and what's number two? How do we sequence our steps? So someone's 39 years old, for example. They say, look, my number one objective is getting pregnant, right? And I say, look, in that situation, if your number one objective is getting pregnant, time, like you said, Dr. Mary, is of the essence. We know that egg quality is a very clear known risk that reduces the chance for pregnancy. We need to tackle that first, and we need to help you freeze your eggs first. Now, if someone comes to us and says, look, my number one priority is treating my fibroids. I'm 34, I'm 33, and you know what? I want to get pregnant, but I don't want to get pregnant today. I want to get pregnant in 2, 3, 4 years. Then at that point, it's a very easy conversation. You say, look, it really depends on your personality type. If you want to, cover every single base, then yeah, of course, we'll freeze your eggs, and that's a very reasonable thing to do. We can either, unfortunately now freeze either eggs or embryos, and again, you speak this better than I can, which is a tremendous, improvement from where we were in the fertility world just as recently as 5, 10 years ago in terms of success rates. Or if you're fine with the risk-benefit ratio, then we treat you with UFE, we treat you with myomectomy, we treat you with whatever you want, and then we'll worry about pregnancy next. And then as to your point about how much time we wait, so both with a myomectomy and with an embolization, we will recommend waiting 6 months. So for myomectomy, it's very clear in the literature. The risk is rupture. For uniform embolization, it is not as clear, but we like to be conservative. And so we say 6 months for specifically the point that you're getting at, we call vascularization of the anatomy. As you know, Dr. Mary, the blood supply to the uterus is remarkably rich, remarkably rich. Mother Nature knew what it was doing, right? And so we have essentially this incredible arcade that comes in from all different angles and all these different connections from all different sides to bring blood supply to the uterus. Blood supply to the uterus when a uterine fibromization is performed is not cut off. They simply reduce the blood supply to a significant degree to the areas that supply not only the fibroids, but also when someone has something called adenomyosis, which is another condition that we'll talk about separately, but this is a great example of how this technology can be implemented in such a dramatic, world-changing way. I'll talk about adenomyosis a little bit later if time permits, because I think it's one of the remarkable evolutions in modern medicine, my personal humble opinion. We went from a scenario where everyone was getting hysterectomies with this diagnosis. That was the only way to diagnose or treat it, to the point where now we can diagnose and treat without needing to remove the uterus with super high success rates. But putting that aside for a second, sorry, Dr. Mary, you were going to say something.
That's amazing. I honestly didn't know about it.
Yeah, no, we should definitely talk about it if time permits, because I think it's worth it, and it's really one of the, I think in my opinion, significant evolutions that's happened. But going back to your point, Dr. Mary, in terms of the vascular supply to the uterus, in terms of risks for implantation, as you know, Dr. Mary, if we do nothing, it's all relative. Baseline risks. If someone doesn't have any treatment for fibroids, what are the risks for fibroids in pregnancy? Well, we already know that may impact fertility, right? We already know, depending on the location, it can reduce the chance for implantation altogether. 2, we know that once someone does get pregnant, we also have a risk of, like intrauterine growth restriction, because you don't have enough blood flow that's going there, and blood flow is being taken by the fibroids. We have risks of miscarriage, high risk of C-section, higher risk of pregnancy loss. All of these concerns, bleeding, postpartum hemorrhage, these are all risks that happen if we do nothing. If we do a myomectomy, there's risks that we damage the uterus. There's risks that we impact the tubes. There's risks that we have to do a larger procedure like hysterectomy. And so I think when you put it in context, all of these procedures have minor risks. It's a question of how someone wants to weigh the benefits and drawbacks. Because at the end of the day, most people who are suffering usually will decide to do something rather than just sit back and not have any relief. And I think the question is, how do we do that while maximizing our chances, improving our chances as much as possible for good things to happen, and reducing our chances for bad things to happen?
Well, that's huge, because again, so Dr. Gohar, it's clear cut that it does not affect implantation in general. Is that right?
Look, I think clear cut is a strong term. I think that as far as we know, based on the data, the fertility rates after myomectomy and UFE all the research I've seen, they're either equal, or some of the newer data, especially what's coming out of Europe, says that UFE is actually superior.
Right.
And so whether it be fertility rates, whether it be in terms of miscarriage rates and continuing pregnancy, the data is extremely comparable. The difference is, one of the major differences, and I think this is where people get lost in some of the details and the nuance, in my personal opinion, and we don't have a stake in this game. At the end of the day, at VB, the way we look at ourselves is we do all the different treatment options. We do myomectomies, we do the uterine fibrilizations, we treat with medication, we even do hysterectomies if it's necessary, if it's medically appropriate. But at the end of the day, when you compare them, one of the big differences between the two that people don't talk enough about is recurrence rate. The recurrence rate when you do a myomectomy, right? When someone has one fibroid, the recurrence rate is 10%. When people have two or more fibroids, based on the latest data from ACOG, when you have two or more fibroids, the recurrence rate is 70%.
Wow.
We don't know why, but you're talking about a 70% chance that we're going to be back dealing with the same problem in a year or 2 years or 3 years. We don't know how long. That's incredible.
And going back to the myomectomy is more scars and more problems. I used to do myomectomy as a resident. They really, they bleed a lot. And some patients get admitted. They need blood transfusion. Sorry, I'm not pro major surgeries. I'm being honest with you. That's why I'm very interested in the UFE part. Now, so
to finish the point of comparison, when we have a uterine fibrillation that's performed, and this is where people get a little thrown off sometimes, so I want to be super clear about this. When we have a complete treatment, and there's a distinction between what we call a partial treatment and a complete treatment. It's because there's two possibilities when someone does a uterine fibrillation. Either we got all the fibroids, or we got most of it. If we got all of it, it's not a subjective, how do I feel about it, what does it look like? It is super clear, right? The patient tells us, I feel a dramatic improvement of symptoms. Whatever the symptoms were, heavy bleeding, painful cycles, pressure symptoms, pain with sex, urinary symptoms. I feel a dramatic improvement, which of course for us is our North Star, it's the patient's symptoms and the patient's subjective feelings. And then objectively on the MRI, we do a second MRI, it's like a before and after picture. We see a complete change in the picture that we saw prior. So those fibroids that were enhancing prior, we measure this actually as percentage points that were enhancing, say at 70% or 80%, now have shrunk and now are non-enhancing. They no longer are picking up any more contrast. That to us is a complete treatment. If the patient has residual symptoms and or has some areas still of enhancement, we didn't finish the job. In that scenario, we will go back for a small touch-up. We will close off any remaining areas. But once we get to that endpoint, and this is where I think the data often gets misarticulated. Once you have a full treatment, the recurrence rate for uterine fibrillation is only 1 or 2%. They almost never come back. Because if you think about it, it's like you went, remember you and I talking about this last week when we were talking about the different analogies. It's as if we're talking about weeds. Someone created a camera where you went under the soil and you plugged off each one of the roots. And so the roots, once they're treated, cause the entire weed to wilt away and go away. And so that's the distinction. We talk about a 1 or 2% recurrence rate versus 10 or 70%. That's a huge difference. And many people, when they think about, hey, I do a myomectomy, I have to then, do a C-section because it's not safe to do a vaginal delivery. That's procedure number 2. And then, sometime in the near future, I'm going to have this come back and I'll have to do a third procedure. That's pretty daunting for the average patient.
So you don't need to do C-section after UFE? But
no, absolutely not. You're absolutely fine to do a vaginal delivery after your fertilization.
That's huge. Now, someone was thinking, which one is less painful? Like what is, yeah.
It's a good question. Honestly, I think that's a subjective measure that's hard to measure. I think they all hurt, to be frank. I've done so many myomectomies over my career, and I think as a team, we see so many of our patients do either these myomectomies, hysterectomies, embolizations. I don't want to make any of this sound like it's all rainbows and unicorns. They hurt, right? Surgery doesn't feel great, especially post-op day 1 and post-op day 2. But I think the difference between the treatment options is that when you talk about something that's minimally invasive, when we do something that's laparoscopic or robotic or with embolization, is that everything is just way shorter. You take something that takes weeks and months, you compress them into days or hours. And so if you're in pain and you're taking medications, right, like we're not going to let you suffer on your own. Our doctors and our nurses are super attentive. We have an open door policy. I don't know if you know this, Dr. Mary, but for example, we have an open door policy for all of our patients at any time for anything, but especially post-op. On any day that we're open, Monday through Saturday, literally a patient can pick up the phone and say, hey, I'm on the way. And we will always get them squeezed in. And so you have a lot of support between the nursing staff and the doctors. We have even a process what we call always on post-op day 1 or post-op day 2. So there's a tracking for this stuff, and we have it down to a science. And I'd say, look, there's no question, even with all of that, it can hurt and it can be uncomfortable. Some people will say myomectomies hurt more, fibromization hurts more, hysterectomies hurt more. It really depends on the person, the pain tolerance, the medication. There's so many factors that go into pain. But yes, I think most people would say, look, we're trading pain that's short-term for symptoms relief that lasts almost a lifetime.
Nice. Now, someone is asking, is there any indication or contraindications to go through, the radial area or femoral?
Yeah, so it's often related to someone's anatomy, not so much contraindications. So yes, there are contraindications related to the anatomy. Dr. Bilal, our head of IR, Dr. Lean, or Dr. Axelrod, or Dr. Levin, any of our IRs can describe this a lot better than I can. But they'll talk to you about the different types. They actually letter them. There's like type A, type B, type C, type D. And so they look at the anatomical division of the blood vessels that go to the arm. And there's, I believe, one that occurs in less than 5% of people that makes it so that someone is not a good candidate for a radial approach. So other than that, and other than someone having, for example, got good breast cancer on that same side, that might impact the way blood flows in that particular arm and the lymph nodes that may have been removed related to it. There are a few exceptions, but almost nearly everyone is a really good candidate for a radial approach. But I wouldn't let any of our patients or viewers get too hung up on that, because really you're talking about something the size of a freckle. We literally will challenge our patients to point out their incision site 2 to 3 weeks after the procedure. Wow. So it's really quite remarkable.
That's amazing. I mean, that's why I'm attracted to this. It's no scars, you don't have to do C-section, you don't have to, you can go to the beach, no scar on your belly. I love it.
It's really quite remarkable. Dr. Mary, one of the analogies one of the examples that I'd like to share that I think is really relevant to what we're talking about is, if you think about this evolution that's happening in medicine, you and I both are in our 40s, right? If we go back to the way our grandparents were doing, I don't know if we talked about this at all. If I'm repeating myself, please let me know, because I can't recall if I've shared this with you before. But if you think about what was happening when people had cardiovascular disease back in the in the 1970s and 1980s, everyone was getting pretty much open heart surgery, right? They had to make an incision in this chest, right through what's called the sternum, the bone that's right here, and they literally would have to open up the rib cage. And then the same surgeon would go into the leg, and they would cut inside someone's leg, and they would take vessels out of the leg, snip them up, and shape them so they were the right size, and they would put them inside the heart. And they would call this a coronary artery bypass graft, right? And this is what everyone did, right? Cardiovascular disease. Everyone. Either that or you die. There was no other choice, right? And so these were these huge surgeries that would take hours and hours and hours and months and months of recovery, right? Now, if you talk to cardiologists, it's a fraction of what happens now in cardiology. Yes, it's still done when necessary, but almost everyone is done how? Through a small incision, usually the size of a freckle, either in the wrist or the groin. They go in under camera guidance, the cardiologists, what they call interventional cardiologists instead of interventional radiologists, and they go in and they either close things off or they open them up. And someone goes home literally the same day, instead of spending weeks at the hospital and recovering for months, if not years. And so the difference between that evolution in cardiology is not unsimilar or dissimilar to what I'm describing here within women's health. And there's so many other examples of this in medicine. Like I could go on and on. It used to be when people would have traumas in the emergency departments, it would be the same thing. Everyone who had trauma would have an incision from here all the way down to the belly. We talk about from the xiphoid all the way down. And we have to open them up and look inside. That was the only way to fix them. The vast majority of these patients are now being also fixed through, guess what? Interventional radiologists and vascular surgeons. And they don't have to go into the belly for the vast majority of these patients.
Well, that's amazing. That's why the UFE, from the time I was trained, really helped significantly. Now, is there a difference in the material where with the embolize the fibroids, and does it go away with time, or it stays this forever?
It's a terrific question. So these materials, these embolic materials, have been perfected and studied for now over 30 years. And because, again, they're not just being used in this purpose, being used for people who have gastric bleeds, and people who have abdominal bleeds, and people who have other issues in their body, we've had a chance, even in the brain, we've really had a chance to study this over the years. And there are a few different products on the market now, a few different manufacturers. They've been studied and tested immensely. Some of them dissolve and are just temporary. Others stay there. But with the way I would describe them, if you think of tiny little gelatinous beads that literally are like Jello, that's what most of them look like. Some of them look more like grains of sand, and others are more gelatinous. But at the end of the day, their job is the same. It's to slow blood flow within a target area. And they've been able to get to a point now, and I think this is maybe the point you're getting at, Dr. Mary, depending on the organ, depending on the situation. So when we do embolizations, for example, for someone who's got postpartum hemorrhage, it's different than if we're doing an embolization for someone who's got fibroids or adenomyosis. We will choose the size and the type of embolic based on someone's anatomy and based on what we're targeting. So for adenomyosis, for example, they'll actually use smaller embolics than we'll use for fibroids. And it's really quite amazing.
So tell us a little bit about, this is a huge subject, because I can tell you I have plenty of patients with adenomyosis, and a lot of patients don't even know that we have adenomyosis, but it causes recurrent implantation failure, thin line, inflammation, heavy periods. It's really underrated because the diagnosis is hard, because you really need MRIs, in my opinion, correct me if I'm wrong, is the best way to diagnose adenomyosis. But like you said, the treatment is really hysterectomy. A lot of those patients don't have babies. So tell us, and I never knew that UFE is done for adenomyosis until now. Tell us a little bit, how can you get tissue without affecting the lining of the uterus and implantation?
Yeah, I can't believe this is the first time you and I talk about this topic, because I am equally as passionate about it. As passionate as I am about fibroids, this to me is like one of the great, gray areas in women's health that has really bothered me for so long, for similar reasons, right? I mean, I think adenomyosis, let me just describe kind of the scenario that would happen to women in New York City as recently as 10 years ago. Until today, in most parts of the country, in most parts of the world, patients would go in to their doctor, to their OB/GYN, and their symptoms would quack like a duck and look like a duck. The duck in this example is fibroids, right? So they would have almost identical symptoms, right? Heavy bleeding, painful cycles, pressure symptoms, pain with sex, or urinary symptoms. Any of the above or all the above, right? And they would go and complain to their doctor, and the doctor would be like, look, I'm really sorry to hear that you're having these symptoms. Let me see what's going on. And at that time, ultrasound was in its infancy. They could hardly see anything. They would just look at this grainy picture. They couldn't see anything. So they would come in, they would do an exam. They would do what's called a bimanual exam. Every single GYN visit involved it, because it was the only way to look inside the body. We'd have to use our hands, and we'd feel the uterus to see whether or not there were bumps, there weren't bumps. So the doctor would be like, look, I don't feel any bumps. Maybe you've got fibroids that we don't know about, but more likely, you probably have something called adenomyosis. So what are we going to do about it? Well, we're going to wait a little bit. We're going to see if the symptoms still go on. But then if there's nothing else, we're going to take you to surgery. What kind of surgery? Well, unfortunately, there's only one option, and that's hysterectomy. We got to take your uterus out. That's the only way to diagnose the problem, if you can imagine. And it's the only way to treat it. And so, in my opinion, it was heads you lose, tails you lose. It was the Salem witch trials of modern medicine, right? Not because the doctors didn't want any better, but because that was all they had.
It's nasty. Very nasty adenomyosis. Very nasty.
Horrible. And so these patients would have like life-changing symptoms. And so ultimately, what has changed, Dr. Mary, is two major components on the diagnostic side and one on the treatment side. On the diagnostic side, in my opinion, ultrasound has made dramatic improvements. The difference between ultrasound today and 10 years ago, let alone 20 years ago, is massive. We can see with far higher accuracy, based on the data today, ultrasound can see, diagnose adenomyosis with an 80% success rate, 80% sensitivity rate. When we look at MRI, that's the second diagnostic criteria that you're referring to, we get to a 90% sensitivity rate, right? So between those two modalities, we've really improved our chances for diagnosing that condition. There's a whole bunch of things we'll talk about what that is, and I can even draw what it means in a second when we talk about fibroids, because I don't know if enough of our patients understand what this condition is. And I think it may help, whether we're talking about fibroids or adenomyosis, to understand the treatment in a more visual way. And then on the treatment side, our tool when it comes to uterine fibroid, or in this condition we call uterine artery embolization, has been a game changer. Because we've learned over the past decade, and a lot of the research started initially in Asia, in countries like Japan and in South Korea, we've learned that this technique that we've been using now for over 30 years for fibroids is remarkably effective for adenomyosis as well. We use slightly different sized beads, and we have a slightly different approach, but the technique is more or less the same, and the symptoms can be game-changingly different before and after.
Wow. That's amazing. That's really amazing. Very amazing. So, yeah, we need to talk about, I really should mention this to my patients. I really do, for the adenomyosis, because it's really common.
Yeah, Dr. Mary, again, I can't believe we didn't discuss it prior. It is a much more common problem when we look for it and we listen more closely and we do the necessary investigations. So I do agree, it's very frequently missed or misdiagnosed or misunderstood by the majority of patients and practitioners in our community.
Right. So is there anything else for, we have a few more minutes, is there anything for fertility patients, any advice regarding fibroid treatments? Now, someone asked what causes fibroids. I think we discussed this last time. Just give us a summary. Really appreciate all the that you did. They were really amazing. They're available on my Instagram. I saved them all, and I believe on yours too. But because it's an issue that's extremely common. We don't know what causes fibroids. We know it's more common in African American. We discussed that last time. We know that so many genes can affect the fibroid development. We talked about, what symptoms it causes, what diet and other changes, exercise, and what else can be done to kind of help fibroid symptoms. We talked about that in the previous sessions. We talked about treatment. Is there anything we need to know in the fertility world about fibroids?
Yeah, I think your summary of our previous conversations are very helpful. I agree very much, Dr. Mary. I think that I think that when you think about a problem as prevalent as fibroids, when you talk about the fact that 30% of women by the age of 35, right, the reproductive age, will have this problem, that Black women are 3 times more likely than other ethnicities to have this problem. We don't know why. It's just what we see. And you see that further, that as many as 70% of women will have this by the age of 50, right? And so our reproductive age, spectrum has really grown dramatically due to the work of people and pioneers like yourself, Dr. Mary, right? The fact that we've gone from, only, from 20 to 30 or 35 to now pushing it to 40 or 45, and now people getting pregnant at 50. It becomes more and more relevant, right? When you recognize that 70% of your patients or my patients by the age of 50 may have this problem, we have to begin to really examine this more closely and recognize its impact. So from a fertility perspective, specifically in talking about fertility, fibroids can make it harder to get pregnant. They can interfere with, the pathway for sperm and egg to meet. They can make it harder for implantation to occur. They can distort the cavity. They can distort the tubes. They can cause bleeding or surgeries that result in scar tissue and other problems. And so there's this chain reaction that occurs. And I think the problem with fibroids is that often these are slow, gradually, progressively worsening conditions. So they slowly progress over time. And as they progress over time, they cause people more and more problems. And so it's really unfortunate, but I think fortunately we live in a wonderful age, despite all the craziness that's going on around us these days. I know very few of us really feel like we live in great times because of all the craziness we've all been dealing with for many reasons outside of medicine. But when we think about where we are in the medical community compared to where our parents were, where our grandparents were, our ancestors, my God, we're so fortunate. I mean, I was one time in this conversation with my son. He stubbed his toe, when he was like playing outside in the backyard, and I had to like disinfect his toe, and he had to like nurse it for like a couple of weeks, and I had to explain to him. I said, look, Adam, if this happened to you, 50 years ago before we invented, or 70 years ago before we invented antibiotics, I mean, for all we know, you could have lost your foot, you could have lost your entire leg, or even your life. All of us could have. It's why the life expectancy was so low. Because you can get a toothache or like have a wisdom tooth get impacted, and that was it. And so
didn't have COVID or monkeypox.
I know. But they had the plague, and they had the Spanish flu, and they had all sorts of stuff. And you know what? The regular flu killed them, or the regular pneumonia killed them.
That's very true. So, well, Dr. Gohar, I cannot thank you enough. I really would like to have in the future a couple of sessions with the interventional radiologists who do the UFE, or uterine fibroid embolization, at Viva Eve, to show our viewers how it's done, and to kind of reassure them that there are ways that's not invasive to treat fibroids. But
no, Dr. Mary, I'd be happy to do that, happy to arrange it. I know that our interventional radiologists would love to come and join us. If you'd like, I mean, I actually have our monitor here. If someone would like, if we have time will permit for us to do a short graphic representation of some of the things we were talking about. It might help the viewers visualize a little bit. If it's not a good time, you feel like we're a little short on time, then we can save it for the next session.
As a separate session on its own, because I don't want to rush it, and I really think this is very important for our viewers. I really do.
I agree. I have no problems with that at all.
So you know me, I'm OCD. Like if something I need to do it like in my brain. But now, if anybody, so you mentioned something very important, is that because a lot of women are freezing eggs and embryos, and they're coming to use them later on, and you mentioned 70% of women have at some point fibroids, and yes, we're gonna see a lot of women in their 50s, if they're healthy, of course, pregnant with their own eggs, because everybody's freezing, right? And a lot of people are, what can I say? I mean, some labs, believe it or not, they're like, there's no more space to freeze eggs and embryos. This is how much it's popular, which is great. It makes us happy, right? But then they're hit with a new problem, which is fibroid. So it's gonna be more common, what I'm trying to say, in our fertility patients over the years. Also, I have a lot of patients who had fibroid removal just because their doctors or their fertility doctors could not reach their ovary to do egg retrieval. I'm gonna brag a little bit here, but we at RFC, we do egg retrieval.
An abdominal approach.
With a tiny needle also, you can't see anything. So you don't need to remove fibroid or myomectomy.
Which I love, by the way, Dr. Mary. I know when you send me someone, we have to move fibroids to get to their eggs. You really can't get to their eggs.
Yeah, we can, from anywhere.
Right. If you can't get to them, I know no one can.
But that's something is also important, because I see patients also being advised to do major surgery in order to get to their ovary, and I really don't think they need that. So now, finally, tell us, if patients want to see you, if they have fibroids, and make an appointment with Viva Eve, how can they reach you, Dr. Gohar, and your team?
Absolutely, yeah. I mean, vivaeve.com is the best way to find us online. You can often book online. You can also call us directly, the old-fashioned way. But Viva Eve is VIVAEVE, just like the name Eve.com. So Long Live Eve is where the name came from. And the phone number is 212-988-2111. Again, 212-988-2111. 2111. So please, we'd love for you to, any of your viewers, to come and join us and visit us. There's also a wonderful tour of our space that they can find on our Instagram feed.
I'm actually in the, and this is Viva. It's so beautiful. It really is just amazing. Like when I look at my office and your office, I'm like, my office is so embarrassing.
No, Dr. Mary. It's about what's inside that counts. So it's the people, it's the service, it's how we take care of our patients that patients really resonate with. But no, we on purpose, as you know,
you're very close to my office. You're like 5-minute walk, literally.
We're very close. Exactly. You literally walked over.
I literally walk over, like seriously. So it's really closer than I thought. But thank you so much, Dr. Gohar and Viva Eve. We're definitely gonna have more sessions. If you guys have any questions regarding, or you want to reach Dr. Gohar or Viva Eve, feel free to send me a DM on Instagram, and I'm more than happy to connect you with Viva Eve. Dr. Gohar, thank you so much for your time.
Thank you, Dr. Murray. It's been a pleasure.
Bye-bye.